Welcome back to the deep dive. If you are a learning nurse, or really anyone who gets that our existence is just this incredibly fine-tuned biochemical process, then this is absolutely the deep dive for you.
It really is.
Today, we're cracking open what I think is the cornerstone of acute care. I mean, it's the entire metabolic engine of the human body. We're tackling fluid, electrolyte, and acid-base balance.
A big one.
It is. This is the stuff that underpins almost every single critical patient interaction. And we're using Chapter 10 of Brenner and Sutter's 15th edition as our definitive map.
The very good map.
Yeah, our mission is to take this really dense, sometimes intimidating chemistry and turn it into a complete, accessible roadmap. We're pulling out the high-yield, need-to-know stuff that helps you anticipate problems, not just react to them.
And that anticipation, that's everything. When we talk about fluids and electrolytes, what we're really fundamentally talking about is maintaining homeostasis, that dynamic process where the body is constantly adjusting to keep its internal world stable.
Right.
Every disease, every major medication, every trauma, it all throws a wrench into this balance. The ability to spot those subtle shifts early. That's what defines expert nursing. So we're going to build your clinical eye for these nuances, starting at the very, very beginning. Okay, let's do it. Let's unpack this chemical foundation, starting with the simplest idea, the body fluid basics. We are essentially a collection of solutions. You've got a solvent water or plasma, and then you have solutes, which are the dissolved particles, or electrolytes.
Right, we're basically fancy bags of salt water.
Exactly. And the book tells us that about 60% of an adult's body weight is fluid. But that percentage is not static, right? We have to remember that, younger people, men, and people with less body fat, they generally have a higher percentage of total body water.
And that really matters. It matters when we're calculating medication doses or trying to estimate someone's dehydration risk. It's not a one-size-fits-all number.
And this massive amount of fluid, it's not just one big pool. It's strictly compartmentalized.
Very strictly. We break it down into two major divisions. The first is the intracellular fluid, or ICF. That's the fluid inside the billions of cells in your body. It is the single largest compartment. We're talking about 2/3 of your total body fluid is right there. It's the powerhouse where all metabolism is happening.
And that leaves the other 1/3 as the extracellular fluid, the ECF. And this is a compartment we as nurses talk about constantly because it's what dictates your circulatory volume, your perfusion, everything.
And even that ECF is broken down further. It has 3 key subdivisions.
The first being the intravascular space. That's your plasma. The fluid part of the blood that's actually circulating. It's about 3 liters of the, 6 liters of total blood volume.
Then you've got the interstitial space. This is the fluid that bathes the outside of the cells. It sits right between the cells and the capillaries. This is a huge reservoir, maybe 11 to 12 liters. When you see someone with generalized edema, that fluid has moved from the intravascular space into this interstitial space.
Okay, and the last one, the smallest one, the transcellular space. Only about 1 liter. This is all the specialized stuff. So cerebrospinal fluid, the synovial fluid in your joints, pleural fluid, pericardial fluid, all those little collections.
So the lifeblood of this whole system is movement. It's the flow of solutes and solvents across these semi-permeable membranes that separate all these compartments. Which brings us to what the book calls the big 4 transport mechanisms. This is so fundamental. Let's walk through these, starting with the passive ones that don't need any energy.
Okay, first up is diffusion. This is the passive movement of the solutes, the particles themselves, from an area of high concentration to low concentration. It's just a simple downhill movement.
We see this all the time with breathing, right? Oxygen diffuses into the blood, CO2 diffuses out.
Exactly. Or when sodium passively moves into a cell just because there's way less sodium inside the cell than outside, it's following its gradient.
Okay, so next is osmosis, and here the action flips. Now we're talking about the fluid moving.
Right. Water moves across that semi-permeable membrane, and it typically goes from an area of low solute concentration to an area of high solute concentration. The classic shorthand everyone learns is water follows the salt. If you have a ton of sodium in one compartment, water is going to get pulled toward it osmotically until things even out.
Until the concentrations equalize.
Exactly. The third one is filtration, and this is all about pressure. It's purely pressure-driven. Think of it like a coffee filter. Water and the dissolved solutes move from an area of high hydrostatic pressure to an area of low hydrostatic pressure.
And that hydrostatic pressure, that's just the physical force from the heart pumping, pushing the blood through the vessels.
That's it.
And the clinical connection here is huge. The kidneys filter an incredible 180 liters of plasma every single day using this pressure. But it's also why you get, say, pulmonary edema and heart failure.
Explain that.
Well, if the heart fails, the pressure builds up behind it. The hydrostatic pressure in the capillaries just shoots up, and it literally pushes fluid out of the vessel and into the interstitial space, into the lungs. That's a perfect explanation of capillary dynamics. So that leaves the one mechanism that requires dedicated energy: active transport. This uses a specific protein, a physiological pump that's powered by ATP cellular energy to move electrolytes against their concentration gradient. It's actively pushing them uphill. And the most famous one, the one every nurse has to be able to visualize, is the sodium-potassium pump, the Na plus K plus AT pace. This thing is relentless. It's constantly working to keep those massive concentration differences we talked about. It pumps 3 sodium ions out of the cell for every 2 potassium ions it pumps in.
And that one mechanism is why sodium dominates the ECF and potassium dominates the ICF. It creates and maintains that whole electrical environment.
So speaking of concentrations, let's talk about the electrolytes themselves. These are the active chemicals, and we measure them in milliequivalents per liter, or MEQL. The cations are the positive ones: sodium, potassium, calcium, magnesium, and hydrogen. And the anions are the negative ones: chloride, bicarbonate, phosphate, and protein. And that difference in concentration between the ICF and the ECF is just, it's defining. Sodium Na plus F, it absolutely dominates the ECF. And because water follows sodium through osmosis, sodium is the single most important factor for your ECF volume and osmolality.
Yeah, if your ECF sodium level goes up, the body will do anything to protect that volume, including shifting water out of your cells to dilute it.
And on the flip side, you have potassium K plus F dominating the ICF. The ECF concentration is kept in this super tight range, like 3.5 to 5.0 MEQL. And this leads us right to a huge clinical insight.
Because most of the potassium is held inside the cell, where its concentration is really high, even tiny little changes in the ECF potassium level are extremely dangerous. They radically change the resting membrane potential of your nerve and muscle cells, especially the heart.
This is the why. Why is hyperkalemia so deadly so fast? When ECF potassium rises, it makes the heart muscle cells really excitable, but then they can't repolarize properly.
And that translates immediately on an ECG into cardiac rhythm disturbances, VFib, asystole, things that can cause death in minutes. That's why potassium imbalances are always the highest priority in electrolyte management.
Absolutely. Okay, let's refine this idea of fluid movement. Let's talk about osmolality, tonicity, and fluid shifts. Osmolality, measured in osm-Kiesh, that's our preferred lab measure for serum and urine. It tells us the concentration of all those solutes.
And a tightly regulated serum osmolality is paramount, especially for the brain. The body will go to extreme lengths to protect the ECF osmolality because your brain cells depend on it to maintain their size. They can't swell or shrink without causing major problems.
We also have to talk about the 2 forces that govern fluid exchange at the capillary level, those Starling's laws. First is hydrostatic pressure, which we said is the pushing force from the heart.
And the second is osmotic pressure. This is the pulling force exerted by the solutes. And when we talk about the osmotic pressure that's exerted specifically by proteins, mainly albumin, which are too big to cross the capillary wall, we call that colloid oncotic pressure.
And that colloid oncotic pressure is the reason blood volume stays in the vessel.
That's it. If a patient is severely malnourished or has liver failure and can't make enough albumin, their oncotic pressure drops. There's nothing pulling fluid into the vessels. So the hydrostatic pressure wins, fluid leaks out, and you get widespread edema, even if the patient is technically hypovolemic inside their vascular space.
Which leads us perfectly into how we manipulate these shifts clinically using IV solutions, or tonicity. This just describes the concentration of a solution relative to your blood.
Okay, so first, isotonic solutions. Things like 0.9% ACL normal saline and lactated ringers. They have roughly the same osmolality as blood. Their whole purpose is volume expansion of the ECF. Since they don't cause any major fluid shifts between the ECF and ICF, they are the first line for hypovolemia, for treating shock or acute blood loss before you can get blood products.
Then we have hypotonic solutions like 0.45% ACL or half-strength saline. These are less concentrated than the blood. So when you infuse them, they move water out of the ECF and into the ICF.
So their main job is cellular hydration. You'd use this for something like hypernatremia, where the cells have shrunk from pure water loss. But you have to be careful. Give too much too fast, and you risk dropping their blood pressure, or worse, increasing intracranial pressure by making the brain cells swell.
And finally, hypertonic solutions. things like 3% ACL or IV mannitol. These are super concentrated. They exert a powerful osmotic force that pulls water out of the ICF and into the ECF.
So they cause cellular dehydration, which sounds bad, but it can be life-saving when you're treating severe cerebral edema. Pulling fluid out of those swollen brain cells is the immediate goal.
Let's pause on mannitol for a second. It's a non-resorbable sugar alcohol.
Mm-hmm.
The mechanism here is so important. Once you give it, it gets filtered by the kidney, but it doesn't get reabsorbed by the tubules.
Right, so it just sits in the tubule acting like this massive solute, creating an osmotic gradient that just drags tons and tons of water with it for excretion.
I call that process osmotic diuresis. Exactly.
Okay.
Before we move on, we have to clarify a concept that new clinicians often get wrong. Third spacing.
Okay. Third spacing is when your ECF fluid moves into a non-functional area, a space that doesn't contribute to the body's equilibrium. So the fluid hasn't left the body, but it's now unavailable to the circulation. Think about ascites, pleural effusions, or the massive blistering after a wound.
And the critical clinical insight there is that the patient can look outwardly swollen, have a huge abdomen, but at the same time be profoundly hypovolemic in their intravascular space. The fluid is moved out of the circulating volume.
So what's the key early sign of that?
Decreased urine output, even if the patient is getting what seems like adequate fluid intake. The kidney sense that dropped intravascular volume and they clamp down hard to compensate. That sets the stage perfectly for regulation. Let's move into part 2, the body's control panel. We need to actually quantify this balance. A normal daily intake and output, or INO for a healthy adult, is roughly 2,500 millimole of tech. Okay, so looking at intake first, you get about 1,000 millimole from oral water, 1,300 millimoles from food, and about 200 millimoles from just the metabolic water of oxidation.
And output.
The majority is urine, about 1,500 millimoles a day. Clinically, we use that rule of thumb that urine output should be at least 1 ml per kilogram per hour.
And the rest of the loss is crucial. We call it insensible loss. Fluid you can't easily measure. About 300 milligauls from the lungs, the water vapor when you exhale, and 500 milliliters from the skin, from perspiration you don't even see, plus about 200 milliliters in feces.
Which is why that quality and safety alert in the chapter is so important. When fluid balance is critical, you have to meticulously record every single route of gain and loss. Everything.
The regulatory organs are the real MVPs here. The kidneys are the absolute champions. They filter 180 liters of plasma a day. Their job is just comprehensive. They regulate ECF volume and osmolality. They adjust electrolyte levels, control pH by retaining or excreting hydrogen ions, and they excrete all the metabolic waste. If the kidneys fail, the whole system just collapses.
Then you've got the lungs. They're the body's rapid response team. They get rid of that 300 ml of water vapor, but their main job is in acid-base balance. They rapidly control CO2, which forms carbonic acid.
So if you retain CO2, you hypoventilate, your blood becomes acidic. If you blow off too much CO2, you hyperventilate, your blood becomes alkaline. It's a very fast-acting system.
And the heart and blood vessels, their job is just to maintain adequate pressure to ensure the kidneys get perfused. If the pump fails, like in heart failure, the whole regulatory system gets these false signals and it just runs away from itself.
And that failure often involves the really complex endocrine and neural regulators. Let's start with the pituitary, which releases ADH, or antidiuretic hormone, also known as vasopressin.
ADH is made in the hypothalamus, but it's stored in the posterior pituitary. And it gets released when your osmolality increases, so dehydration, or when your blood volume drops, like from a hemorrhage.
And what does it do?
It acts on the nephrons in the kidney, and it increases the reabsorption of water back into the blood. This raises blood volume, and it makes the urine very concentrated. It's the body's #1 water conservation tool.
Okay, next, the adrenal glands. They secrete aldosterone. Aldosterone makes you retain sodium and water, and in exchange, it makes you lose potassium. Cortisol, the stress hormone, also contributes to sodium and fluid retention when you have a lot of it.
We also have the parathyroid glands, PTH. They regulate calcium and phosphate. We'll get into that critical inverse relationship between calcium and phosphate later on.
Neural control involves the baroreceptors. These are pressure sensors in your major arteries and in the atria of the heart. When they sense decreased arterial pressure, a drop in circulating volume, they stimulate the sympathetic nervous system. That increases heart rate, blood pressure, and crucially, it triggers the release of renin. And that kicks off the most famous regulatory feedback loop in the body, the Renin-Angiotensin-Aldosterone System, RAAS. This is essential for a learning nurse to get, not just for physiology, but for understanding so many common cardiac meds. Walk us through it. Why is it so good at controlling volume?
Okay, so it starts when the kidneys sense low perfusion, low blood pressure.
Yeah.
That triggers the release of renin. Renin acts as an enzyme, and it converts angiotensinogen into angiotensin I.
Then the lungs get involved.
Right. The lungs have ACE, angiotensin-converting enzyme, which transforms angiotensinate into the incredibly potent angiotensin II.
And angiotensin II does two powerful immediate things. First, massive vasoconstriction. It dramatically raises your total peripheral blood pressure. Second, it travels to the adrenal cortex and stimulates the secretion of aldosterone.
And that completes the loop. Aldosterone forces the kidneys to reabsorb sodium and water, increasing blood volume, which raises BP even more, all while kicking out potassium. It's an emergency system designed to aggressively protect your circulating volume at all costs.
And the clinical insight is right there. Drugs like ACE inhibitors, lisinopril for example, they block that conversion of A to 2. They prevent the vasoconstriction and the aldosterone release.
Which is why they're so good at lowering blood pressure and reducing the volume overload you see in things like heart failure.
And the body has a counter system to this, the natriuretic peptides, ANT and BNP. These are released by your cardiac muscle cells when they get stretched, a sign of high volume or high pressure, usually from heart failure.
And they directly oppose RAAS. They promote the excretion of sodium and water, which decreases blood pressure and volume. It's a system designed to de-stress a failing heart.
Before we leave regulation, we have to talk about gerontologic considerations. The changes with aging fundamentally alter fluid regulation. Renal, cardiac, respiratory function, they all decline. Total body water and muscle mass decrease.
And most critically for patient safety, the thirst mechanism often becomes impaired. An older adult with fluid volume deficit might not feel thirsty at all, which leads really quickly to significant hypovolemia and acute delirium, which often gets mistaken for a primary cognitive problem.
And interpreting labs can be tricky too. A serum creatinine that looks high normal might actually indicate substantially reduced renal function in an older adult just because their overall muscle mass is lower, so they produce less creatinine to begin with. And the huge safety point for nursing care: older adults have decreased cardiac reserve. If you give them IV fluids rapidly, even small volumes can quickly overwhelm the heart and push them into acute fluid overload and cardiac failure. You have to monitor those IV rates with extreme caution in this population. Okay, moving into part 3. Let's look at the clinical extremes, starting with fluid volume deficit or FVD hypovolemia. This is when the loss of ECF volume is more than the intake, but, and this is key water, and electrolytes are lost proportionally. It's often an isotonic loss.
We have to slow down here and be really clear about the difference between FED and dehydration. Dehydration is purely a loss of water, which results in hypernatremia, high serum sodium, because all the remaining solids get concentrated. FED is often from something like a hemorrhage or GI loss, where you lose both salt and water together.
Causes of FVD are pretty extensive. Vomiting, diarrhea, GI suctioning, massive sweating, not drinking enough, hemorrhage, third spacing from burns or ascites, and endocrine issues like diabetes insipidus.
And the clinical signs, which are laid out in Table 10-4 in the book, they're a picture of the body trying desperately to compensate, to maintain blood pressure.
So what do you see?
You see acute weight loss, oliguria, very little urine, and the urine is super concentrated. Prolonged cap refill, low CVP, low blood pressure, and a compensatory rapid, weak pulse. The patient is often confused, and their skin is cool and clammy.
For diagnosis, the labs give you really strong clues. You'll see an increased hemoglobin and hematocrit, not because they made more red blood cells, but because the plasma volume dropped. It's called hemoconcentration. Serum and urine osmolality, urine-specific gravity, they're all increased as the body tries to save every last drop of water.
The most specific clue, though, is often the BUN to creatinine ratio. Normally it's about 10-1. In FED, the kidneys reabsorb a ton of urea to help conserve volume, so that ratio often jumps to greater than 20-1. We call that pre-renal azotemia.
Right, elevated nitrogen waste that's caused by poor perfusion to the kidney, not because the kidney itself is damaged. And back to nursing assessment for a sec. Skin turgor is helpful, but you have to remember it's less reliable in older adults. For them, checking vein filling in the hands and feet or looking at the tongue for extra longitudinal furrows is often more accurate. And the core safety alert: track daily weights. An acute loss of 1 kilogram, 2.2 pounds, is a fluid loss of about 1 liter. Medical management starts with correcting that volume. If the patient is hypotensive, the first line is always an isotonic electrolyte crystalloid solution 0.9%. Normal saline, lactated ringers to expand that plasma volume fast. Once their BP is stable, you might switch to a hypertonic solution like 0.45% ACL for general hydration.
And this is where the flu challenge test comes in. If a patient is oliguric, you need to know why. Is it volume depletion, or is the kidney failing? The provider gives 100 to 200 milliliters of normal saline over 15 minutes.
And you watch the response.
Exactly. If the kidneys respond and urine output, BP, and CVP all increase, the problem is FVD. If output stays low, the issue is likely kidney damage.
So nursing management is just focused on meticulous monitoring, hourly INOs, daily weights, and being vigilant about vital signs, especially watching for orthostatic hypotension. That's a drop of more than 20 mmHg in systolic BP when the patient goes from lying to sitting. And of course, you're encouraging oral fluids and giving antiemetics to stop any ongoing losses. Okay, let's pivot to the other extreme. Fluid volume excess, FVE, or hypervolemia. This is an expansion of the ECF because of simultaneous retention of water and sodium in isotonic proportions. Like FVD, the serum sodium often stays normal because the whole plasma volume is diluted equally. The causes here are usually compromised regulatory systems, heart failure, kidney dysfunction, liver cirrhosis, or just giving way too many sodium-containing IV fluids. The clinical signs are a mirror image of deficit, acute weight gain again, 1 kilo is 1 liter peripheral edema, ascites, distended jugular veins, crackles in the lungs from pulmonary fluid, a bounding pulse, and high BP and CBP. And the labs show that dilution effect, decreased HGB and HTT, decreased serum and urine osmolality. You assess edema using that pitting edema scale from 1 plus to 4 plus H, and you measure limb circumference.
Medical management is treating the cause, restricting fluid and sodium, and using diuretics. We need to get the mechanism of action here.
For mild to moderate FVE, you'll see thiazide diuretics. They work on the distal tubule. But for severe FVE, you need loop diuretics like furosemide because they act on the loop of Henle where a huge amount of sodium is normally reabsorbed. They are much, much more potent volume removers. And a huge safety point on diuretics. You're not just shifting volume, you're shifting electrolytes. Loop and thiazide diuretics cause massive potassium loss, so you're risking hypokalemia. On the other hand, potassium-sparing diuretics like spironolactone have to be used carefully because they risk hyperkalemia, especially if the patient has any kidney issues. Nutritional therapy goes hand in hand with the diuretics. Sodium restriction can be really severe, sometimes down to 250 milligrams a day. And there's a strong warning about salt substitutes. Most of them contain potassium, which is absolutely contraindicated if the patient has kidney disease or is on a K-sparing diuretic. Sometimes increasing protein intake can help raise the oncotic pressure, which might pull some of that interstitial fluid back into the vessels. So nursing management is that constant cycle. Daily weights, monitoring INO, assessing breath sounds, promoting rest, which actually helps encourage diuresis by reducing venous pooling. And patients with dyspnea, putting them in a semi-Fowler position helps maximize their lung expansion. Okay, now we transition into part 4, the major electrolyte imbalances. Let's start with sodium. Not plus widow, the ECF volume regulator. Normal range is 135 to 145 millieql.
Hyponatremia, so a sodium deficit less than 135 is usually a water imbalance. It's too much fluid relative to sodium, leading to dilution.
What causes that?
Things like diuretics, GI loss, giving too much D5W, which is basically free water, or SIADH syndrome of inappropriate ADH, where the body just holds on to too much water. We also see exercise-associated hyponatremia from people drinking excessive amounts of plain water during, a marathon, while also losing sodium through sweat.
The critical pathophysiology here is cellular swelling, which is shown in figure 10-7. The low ECF osmolality means water just rushes into the cells, causing cerebral edema. An acute drop in sodium under 48 hours has a much higher mortality risk than a gradual one.
The manifestations are all neurologic: headache, lethargy, confusion, nausea. Below 115, the patient is at high risk for seizures and respiratory arrest.
And the management of hyponatremia involves a critical safety alert. When you're replacing sodium, the serum Na+ must not increase by more than 12 NaREQL in 24 hours. Why is that number so specific?
Because rapid correction risks osmotic demyelination syndrome, which is a devastating neurological injury where the rapid ECF changes basically shear the myelin sheath off the nerves in the brainstem. It's catastrophic. So for severe symptomatic hyponatremia with active cerebral edema, the management is urgent. Small volumes of highly hypertonic saline 3% or 5% given very slowly and consciously to stabilize the neurosymptoms quickly, but always staying under that 12 milliQ per day limit. For hypervolemic hyponatremia like in SIADH, the safest treatment is just fluid restriction. Okay, now hypernatremia, sodium excess greater than 145. This means either a gain of sodium in excess of water or just pure water loss.
Common causes are fluid deprivation, especially in older or cognitively impaired adults, hypertonic tube feeds without enough water flushes, watery diarrhea, and diabetes insipidus, or DI, from a lack of ADH. The pathophysiology is the exact reverse. High plasma osmolality pulls water out of the ICF into the ECF, causing cellular dehydration. The shrinking of the brain cells causes all the neurosymptoms. Manifestations include intense thirst, if the patient can sense it, elevated temp, a swollen dry tongue, sticky mucous membranes. The neurosigns are restlessness, hallucinations, and seizures.
Management is aimed at gradually lowering the sodium, no faster than 0.5 to 1 millieq per liter per hour. You'd use hypotonic solutions like 0.45% ACL or D5W, which just provides free water, and you treat DI with desmopressin, which is synthetic ADH. Nursing care is all about providing oral fluids and meticulous neurochecks, watching for signs of too rapid correction, which risks cerebral edema. Okay, next up, the intracellular powerhouse, potassium K plus GES. Normal is 3.5 to 5.0. Hypokalemia, a potassium deficit, so less than 3.5. The causes are usually K-losing diuretics like loops and thiazides, GI losses from vomiting or diarrhea, hypaldosteronism or alkalosis, which shifts potassium into the cells.
And don't forget the DKA connection. When we treat diabetic ketoacidosis with insulin, that insulin drives potassium rapidly back into the cells, which can trigger acute hypokalemia even if their starting level was normal. Right. The clinical signs are all about muscle function. Profound fatigue, anorexia, severe muscle weakness, polyuria because the kidneys can't concentrate urine, and decreased bowel motility, which can lead to a paralytic ileus. And the ultimate risk is always ventricular assistole or fibrillation. The ECG findings are classic. They're shown in figure 10.8b. You see flattened T waves, the appearance of prominent U waves, and ST segment depression. And critically, hypokalemia makes a patient much more sensitive to digitalis, which significantly increases their risk of DIG toxicity.
Management involves diet fruits, veggies, milk, meat, and supplements. Now let's detail the most critical safety alert for 5E supplementation. 5E potassium is never given by high-V push, ever. Not IM, not as a rapid bolus.
Never. It has to be diluted, infused slowly through a pump, usually no faster than 10 to 20 milliQ an hour, and the patient has to be on a continuous ECG monitor. And if their urine output drops below 20 milliliter an hour for 2 consecutive hours, you have to stop the infusion immediately. They can't excrete it, and they'll become dangerously hyperkalemic.
Okay, the other side of that coin is hyperkalemia. Potassium excess greater than 5.0. This is way more immediately dangerous than hypo because of the cardiac arrest risk.
It rarely happens if you have normal renal function, so kidney injury is the most common cause. Other causes are massive tissue damage, crush injuries, burns, tumor lysis syndrome that releases huge amounts of intracellular K+ into the ECF. Or acidosis, which shifts K+ out of the cells in exchange for H+. You also have to think about meds. ACE inhibitors, NSAIDs, K-sparing diuretics all can raise potassium, and you always have to check for pseudo-hyperkalemia. That's a false high level caused by hemolysis from a bad blood draw. If the patient is asymptomatic and their ECG is normal, you have to redraw the blood. The ECG signs are the key to recognizing this emergency. They're in figure 10.8c. The earliest sign, usually around 6 meter EQL, is tall, peaked, narrow T waves. As it gets worse, the PR interval gets longer, the QRS widens, the P wave disappears, and you eventually get sine waves and VFib. Emergency management is a 3-pronged attack. Step 1. Myocardial protection. Give IV calcium gluconate. This stabilizes the cardiac cell membranes against the high potassium. It does not lower the serum level itself.
Shift the potassium temporarily. IV regular insulin and hypertonic dextrose to prevent hypoglycemia will drive K+ back into the cells. Sodium bicarb or inhaled albuterol can also be used to shift it temporarily. And step 3, remove the potassium from the body. This is the definitive treatment. We use things like Kyaxylate, which binds potassium in the gut for excretion, or for the most severe cases, hemodialysis. Nursing care is all about monitoring for muscle weakness and teaching at-risk patients to avoid potassium-rich foods and salt substitutes.
Okay, now we'll move a little quicker through part 5, the secondary electrolytes. These are all defined by their crucial interrelationships. Let's start with calcium, K+ less Lyswa, normal totals 8.8 to 10.4.
Hypocalcemia, so less than 8.8, is often caused by hypoparathyroidism, frequently after thyroid surgery, or renal injury because hyperphosphatemia causes a reciprocal drop in calcium. The classic manifestation is tetany. That's increased neuromuscular excitability. Nurses have to check for the 2 defining signs shown in figure 10-9. Chvostek sign, which is a facial twitch when you tap the facial nerve, and Trousseau sign, which is a carpal spasm you induce by inflating a BP cuff for a few minutes. The ECG will show a prolonged QT interval.
And if the patient's albumin is low, the total calcium level will look falsely low. You have to use the corrected serum calcium calculation from chart 10-2 to find out the true active level. Management is 5e calcium salt, usually gluconate. And here's a major safety alert. 5e calcium must be given slowly and monitored by ECG, high risk of bradycardia and cardiac arrest. And it should never be given with normal saline or any phosphate or bicarb solutions because they'll cause an immediate precipitate. Hypercalcemia greater than 10.4 is usually from cancer or hyperparathyroidism. You see muscular weakness, constipation, polyuria. The ECG shows a shortened ST and QT. Treatment is aggressive fluids, 0.9% NS to dilute and excrete it, often with furosemide.
Next, magnesium, Mg++ long. Normal is 1.8 to 2.6. It's essential for that Na plus K plus pump, and it has a sedative effect at the neuromuscular junction.
Hypomagnesemia, less than 1.8, is critical because it often coexists with and prevents the correction of hypokalemia and hypocalcemia. You have to fix the mag first. The most common cause is chronic alcoholism and severe GI loss. The manifestations mirror hypocalcemia. Neuromuscular irritability, positive Trousseau and Chvostek signs, increased deep tendon reflexes. For management, IV magnesium sulfate is used. This requires another essential safety alert. 4-meg requires a second nurse independent double check and really careful monitoring of urine output. Rapid administration can cause immediate respiratory depression and cardiac arrest. Calcium gluconate has to be at the bedside as the antidote. Hypermagnesemia greater than 2.6 is rare, usually from kidney injury or taking too many magnesium-containing antacids or laxatives. The symptoms are CNS depression, flushing, hypotension, profound muscle weakness, hypoactive reflexes, and depressed respirations. Management is stopping all mag sources and giving IV calcium as the antagonist. Briefly, let's touch on phosphorus, PA, which is 2.7 to 4.5. It's the primary ICF anion, vital for ATP, and has that strong inverse relationship with calcium.
Hypophosphatemia is seen in refeeding syndrome and causes muscle weakness and confusion from a lack of ATP. Hyperphosphatemia is most often from kidney injury and shows up as symptoms of the reciprocal low calcium, like tetany.
And finally, chloride, Cl, from 97 to 107. The major ECF anion, it has an inverse relationship with bicarb. Hypochloremia comes from massive GI loss, like suctioning or vomiting, and is treated with normal saline. Hyperchloremia is often from giving too much normal saline or bicarbonate loss from severe diarrhea, and it leads to signs of metabolic acidosis. Okay, that massive foundation of fluid and electrolyte knowledge is what we need to approach the final, most complex piece of this puzzle. Part 6, acid-base disturbances. This all revolves around keeping the pH in that super tight range of 7.35 to 7.45. The core regulatory system here is the bicarbonate-carbonic acid buffer system in the ECF. We rely on a critical 20-to-1 ratio of bicarbonate, which is HCO3, the base, regulated by the kidneys, to carbonic acid, H2CO3, the acid, which comes from CO2 and is regulated by the lungs, the chemical equation that defines life. CO2 plus H2O gives you H2CO3, which breaks down into H plus and HCO3. The lungs regulate the PCO2, the partial pressure of carbon dioxide. They are fast. The kidneys regulate the bicarb and hydrogen ions. They are slow. It takes hours or days for them to fully compensate.
So let's define the 4 primary imbalances, starting with metabolic acidosis. That's a low pH and low bicarb. It's either a gain of acid or a loss of bicarb, and the body's compensation is immediate and visible. Hyperventilation. We call it Kussmaul breathing, those deep, rapid respirations, to blow off CO2 and reduce the acid load. The diagnosis here requires calculating the anion gap. You take the sodium and subtract the chloride and bicarb. Normal is 8 to 12. The key insight is that the anion gap tells you the cause of the acidosis.
How so?
A high anion gap over 16 suggests you've accumulated unmeasured acids, like lactate and lactic acidosis, ketones and DKA, or uremia and renal failure. A normal anion gap suggests a direct loss of bicarb, usually from severe diarrhea.
Okay. Next, metabolic alkalosis. That's a high pH and a high bicarb. The causes are massive loss of hydrogen ions, usually from severe vomiting or gastric suctioning or taking too many antacids. The lungs compensate by hypoventilation to hold on to CO2.
The signs are often related to the resulting hypocalcemia, like tingling and tetany, because the decreased H+ allows more calcium to bind to protein, making less of it available.
Then, respiratory acidosis. Low pH, high PCO2 over 45. This is just inadequate CO2 excretion hypoventilation. Acute causes could be pulmonary edema or a sedative overdose. Chronic causes are things like severe COPD, The renal compensation is slow. The kidneys conserve bicarb to neutralize the acid.
And this brings up a critical safety alert specific to chronic respiratory acidosis. In severe COPD, the respiratory drive becomes insensitive to high CO2. It starts relying on the hypoxic drive-low oxygen levels to stimulate breathing.
So if you give them high concentrations of supplemental oxygen, you remove that drive and you risk profound hypoventilation and acute respiratory failure. You have to give oxygen with extreme caution. Titrate it carefully.
Finally, respiratory alkalosis. High KH, low PCO2, under 35. This is excessive CO2 loss from hyperventilation, often due to anxiety, panic, or hypoxemia. The signs are lightheadedness and numbness or tingling from cerebral artery vasoconstriction and decreased calcium ionization. Management is usually treating the anxiety or having them breathe slowly. The capstone skill for a learning nurse is ABG interpretation, which is laid out in Chart 10.3. Let's walk through the steps methodically. Step 1. Look at the pH. Is it acidotic, less than 7.35, alkalotic, greater than 7.45, or is it normal, which means it's compensated?
Determine the primary disturbance. Is the PCO2, the respiratory part, or the HCA3, the metabolic part, aligned with the pH abnormality? And step 3, check for compensation. Is the non-primary value moving in the direction it needs to correct the pH? If the pH is normal, the compensation is full.
So for example, if you have a low pH, a high PCO2, and a normal bicarb, that's an uncompensated respiratory acidosis.
Right, but if you have a normal pH, a high PCO2, and a high bicarb, that's a fully compensated respiratory acidosis, probably a patient with chronic COPD.
And remember that mixed disorders exist. You can have two simultaneous problems. If the pH is severely low, and both the PCO2 is high and the bicarb is low, both systems are failing at the same time. That patient is in deep trouble. Okay, in our final section, Part 7, let's translate all this knowledge into practical action. Parenteral fluid therapy and 5E management. 4 fluids are given to provide water, nutrients, electrolytes, replace deficits, or administer meds. Revisiting our IB solutions based on osmolality. Isotonic solutions like normal saline and LR, they expand the ECF, but you have to remember the conversion. You need 3 liters of an isotonic crystalloid to replace 1 liter of blood loss, because those crystalloids quickly diffuse out of the vessels.
And D5W is unique. It's isotonic at first, but the glucose gets metabolized in minutes, leaving behind only free water, so it becomes hypotonic in the body. That makes it contraindicated for resuscitation because of hyperglycemia, and in patients with head injury because it can increase intracranial pressure.
Hypotonic solutions like 0.45% ACL risk moving water too quickly into cells, which can cause cardiovascular collapse or increased ICP. And hypertonic solutions like 3% ACL or mannitol risk circulatory overload. They have to be given into central veins and monitored very cautiously.
Nursing management of IB therapy has to anticipate complications, starting with the systemic complications. Fluid overload presents as increased BP and CVP, moist crackles in the lungs, cough, distended neck veins, dyspnea, and weight gain.
Treatment is to decrease the IV rate. Put the patient in a high Fowler position and monitor their vitals and breath sounds constantly. The serious but rare one is air embolism. Air lodges in the right ventricle, blocking flow. The signs are palpitations, sudden dyspnea, JVD, and hypotension. The emergency treatment is immediate. Clamp the line, position the patient on their left side in the Trendelenburg position that traps the air in the right atrium away from the pulmonary artery, and give them oxygen. But the most frequent concerns are the local complications. Phlebitis, or vein inflammation, can be chemical from an irritating solution, mechanical from a big catheter, or bacterial. It looks like a reddened, warm, painful area along the vein. We grade this using a scale from Chart 10 to 5. The treatment is to stop the IV, restart it elsewhere, and apply warm compress.
Then you have to distinguish infiltration, which is a non-vesicant solution in the tissue, from extravasation, which is a vesicant or irritant solution in the tissue. Infiltration causes coolness, edema, discomfort. Extravasation is severe, it's a grade 4, and it risks blistering and necrosis. You see it with things like vasopressors or high concentration potassium or calcium.
Management for both starts with stopping the infusion and elevating the extremity. But for extravasation, you have to follow your specific institutional protocols immediately, which might involve antidotes or specific warm or cold compresses.
And finally, thrombophlebitis. That's a clot plus inflammation. It causes localized pain, a sluggish flow, and fever. Crucially, if you suspect a clot or an obstruction, you must never irrigate or aspirate the line. You discontinue the entire setup immediately. Flushing it could dislodge the clot and cause an embolism.
Wow, we have covered a massive landscape. From the sodium-potassium pump that drives cellular life, through the endocrine loops that govern volume, all the way to the critical responsibilities of managing high-risk IVs and interpreting complex ABG data.
The core takeaway for you, the learning nurse, is that your role is so much more than just checking a lab value or hanging an IV bag. It is about anticipating the shifts. It's recognizing that a subtle finding, a slightly rapid pulse in an older adult, a quiet abdomen, a small drop in urine output, that might be the first sign of a catastrophic fluid or electrolyte imbalance that needs immediate calculated intervention.
So as you take all this knowledge forward, let's leave you with one final provocative thought that ties several of these critical concepts together. We established that insulin used to treat DKA rapidly drives potassium into the cells, risking severe hypokalemia.
Right.
So if a DKA patient comes in and their serum potassium is initially high normal, say 5.0 because of their acidosis, how quickly should you anticipate that the subsequent insulin infusion is going to cause their potassium to drop below 3.5? And how does the timing of that inevitable shift affect your decision to maybe start prophylactic potassium even when their current level isn't technically low?
That balance between the current lab value, the anticipated shift, and patient safety. That is the art of expert care.
Absolutely. Thank you for joining us for this crucial deep dive.